Good afternoon, everybody, and welcome to today's KLH-OHT Lunch and Learn. Today's session will focus on population health management. Just a few housekeeping items before we get started. This meeting is being recorded. We ask that you please keep yourself on mute during the presentation. Please feel free to ask any questions in the chat, and there will be time at the end of the presentation for questions as well. To begin, Stephanie will talk about OHT clinical priorities and will introduce our guest speaker, Mike Hindmarsh, who will talk about population health management. So I will pass it over to Stephanie to begin.
Thank you, Christine, and welcome everyone. It's nice to see some familiar faces or names anyway in the chat. I'm going to take 3.5 minutes, Mike, and that's it, I promise. So I just wanted, for anybody who's new to our OHT landscape and curious about what the heck we are a collaboration of healthcare providers and organizations that are committed to improving the healthcare experience in our community. We are not an organization. We are not a provider of care. We collaboratively hold a vision that is enabled by improvements in transitions in care, right place, right setting, right provider, etc. We're focused on enhancing from a digital perspective, particularly the ability of providers and patients to communicate and access health information. We're building integrated care pathways and standardizing pathways and clinical processes where possible around chronic disease management, palliative care, mental health, and substance use health. We're really doing all of this work with a very strong focus on equity-oriented population health lens, as well as the provision of navigation supports where appropriate. Next slide, please. So the work that we're talking about today is very much, I'm not sure, there we go. Okay, it's focuses on, really intersects our two priority areas in the OHT. One is primary access, attachment, and enablement, and the other is integrated clinical priorities. So we have been focused for the last 4 years on really building some capacity in our healthcare system to address the needs of our population, knowing that chronic disease management and chronic disease prevalence is certainly high on the list of pieces we need to focus on. So the work that Mike's going to talk us through today is really that opportunity to really develop some integrated strategies around the clinical priorities, particularly around heart failure and COPD that we have been working on for the last 4 years. And as we have the fortune in our OHT of having resources as a result of the primary care investment. So we want to make sure that we step out of the gate properly and in good measure, so to speak, pardon the pun, so that we are really advancing quality clinical outcomes for our communities. So to date, next slide, please. Our work to date around heart failure in particular, which is where we started this journey, has been focused on standardizing patient education materials, which are now available at our local hospitals and primary care clinics variously. And this is a patient passport and education booklet that has received some very positive responses. We've been building the digital infrastructure to support the continuity of care across the continuums of hospital discharge to primary care and back, etc. And we've been working on enhancing existing community resources to support heart failure and COPD in the community. And mostly this has been entailed community paramedicine and remote care monitoring. We have a very active working group that has been very focused for the last couple of years on finding places where we can enhance current capacity. And one of those ways will be the implementation of a population health management framework. And that's what our guest speaker is going to speak to us today about. So I'm going to introduce Mike Hindmarsh now. Mike, I think our careers have intersected for about 25 years, so it's once again a pleasure to have you at a table supporting us. Mike is an established healthcare improvement consultant offering strategic planning, project direction, and technical assistance for implementing chronic disease programs in primary, specialty, and ancillary care settings. Mike's expertise includes quality improvement, system redesign, training in patient self-management support, and practice coaching. Mike has worked in over 200 improvement efforts in the last 30 years in Canada and internationally. He started this when you were 10, right, Mike?
Yeah. Thank you. You're my new best friend.
And his current work is as the RISE head coach for Ontario Health Teams, and that's really the Rapid Improvement Support and Exchange, if I got the acronym right, platform that genuinely supports OHTs in advancing population health management approaches. We're very grateful that this is a support that's provided to us as OHTs through Ontario Health, and Mike and his team are fantastic to work with, and you'll get a slice or a flavor of that today. So I'm going to pass it over to Mike now. Presume you have your own slides you want to share.
Yeah, I'll just share my screen here and hopefully it will work properly. Okay, can people see population health management slide? Great, thanks, Brianna. I'll just put it on slideshow. Okay, so oops, so as I'm going to talk about two things today. There's a lot of content, and so it'll be a bit of a fire hose, but I certainly can be available for follow-up questions. Feel free to ask questions throughout, and I'll stop at various points to see if there are questions. As Stephanie was saying, your job as an OHT is to sort of take the chaos of our current system that's on the left there, where care is siloed and referrals don't work necessarily very well. People are using walk-in clinics, and care is kind of all over the place. And to create an integrated care system with primary care at the heart and the patient at the heart of that system on the right-hand side. One of the tools to get there is population health management. And I'm going to talk more about the 5 steps that RISE has been helping teams with in terms of how to create that integrated care system. Oh, I just have to reduce something here. There we go. Oh, I lost you. How did that happen? Sorry, folks. I'll be right back. Oops. I somehow lost my screen. I'm not quite sure what I've done, so just bear with me. And I will pull this back up again. There we go. So when we talk about population health management, there's all sorts of definitions, but this is the one we've been using, and it's how we improve the overall population health. So rather than thinking of healthcare as one individual at a time, which is certainly important for primary care business, we're thinking about different populations of people and how we can improve care for them. It's an iterative process, and it's based on continuous quality improvement. And a lot of the work that I do with the teams is around the model for improvement and PDSA cycles, which you might have heard of already. What we're trying to do is when we think of the population as a bell curve, we're trying to move that curve from people unhealthy to healthy, but you'll also notice that that curve is being squeezed. And that is around making sure that we have equity in our healthcare, that everyone is able to access and receive the same care regardless of their situation. And certainly there has been a big focus in the OHTs on marginalized populations and people with social determinants that are impacting their health. Here are the 5 steps, and we typically start with population identification. I'm going to talk about each one of these. Then we think about how we segment our populations to understand their needs for care and barriers to care. We go about co-designing models to fix those barriers and to improve care for those different segments of the population. And then when we're ready and believe that the models that we're testing are ready for prime time, we go to implementation and reach, and then have continuous monitoring and evaluation of the system to improve as situations change or as the evidence for care changes. So when we talk about population identification, the OHT has an attributed population. It is a moving population. People are coming in through births, through immigration, mobility, and choice, and people are leaving through death, emigration, mobility, and choice. The key is to keep that full population in sight, and that is the job of the OHT, to improve care for that whole population. Segmentation is really where a lot of the action is in terms of population health management. We have to take a look at different segments of the population and say, what is it they actually need? And there's no single right way to do population segmentation. You can do it any way that makes sense for the subpopulation that you're looking at. So if you have your attributed population, as Stephanie mentioned, you've got your heart failure population, you've got your COPD population, diabetes, so on and so forth. You've got multi-comorbid populations. So depending on which population you're targeting, and for your group, heart failure is one right now, you want to think about how do we segment that population in a meaningful way so that we deliver care properly. Now, to do that, you've got to have good data. And you have data from the dashboard, you have data from inside your system, but it doesn't have to be perfect data. The one thing we say is as you can see on the right there, there's a thing called good enough data, and that is you don't want to expend an awful lot of effort trying to make sure that your data is absolutely perfect. As said down at the bottom there, don't let the perfect be the enemy of good enough. So segmentation is a process. It's not an outcome or an endpoint. It's what you do to get a better understanding of a particular priority population that you might pull from your attributed population. And when we think about segmentation, the general approach that has been taken in the literature is one that's originally developed. It's actually originally developed at a group called Group Health Cooperative that I used to work at, which is now owned by Kaiser. But it's called the Kaiser Pyramid. And we can think of the population of patients for any condition or the attributed population in these layers. So you have healthy patients at the bottom, which are the bulk of patients in the system, bulk of people in the system. You have folks that are rising risk. Maybe they've got a chronic condition and they're at risk for becoming worse or having more chronic conditions. You have folks that are getting increasingly complex. These are high-risk folks that are about 5 to 10% of your population. And then you've got that really heavy user population of people that are very sick and need a lot of care. On the right-hand side of the pyramid is how you can think about the care that needs to be delivered. So for the healthy population, perhaps most of what you need is health promotion and prevention. For people with rising risk, you want better disease management, staying on top of their care, looking into primary care and how you can improve care in primary care to manage those people with rising risk. People that are becoming increasingly complex, care management is likely the route that you're going to go to manage that portion of the segment or that segment of the population. And then, as we know from the Health Links projects, a lot of high intensity treatment teams were created for those 5% that are high users and of the system. So that's sort of the general model of segmentation. When you think about your heart failure and how you might segment the heart failure population, one way you can do it is you could do it through the New York Heart Care Association classification, I think it's called. Anyway, it's a scale from 1 to 4, and I believe that I might get this wrong, so I apologize to the clinicians out there. I think 1 is the most severe heart failure, and 4 is the least. And so you can see how you could fit those into the pyramid there on the left and design care accordingly. So that's one way to think about segmenting the heart failure population. Same can be done for COPD. You can look at the different stages of COPD and segment the population that way and design care accordingly. So I keep saying design care. What do I mean by that? I mean, in the third step of population health management, what we need to be doing is thinking about how do we design care models to meet the needs of those different segments of the population. Your OHT has been doing work on that. Integrated clinical pathways were one way that the Ministry of Health and OH introduced how to design care models. The one that I really advocate for and is Ed Wagner's model called the chronic care model. And what it is a system change model that um, looks at the whole system of care and says, how can we improve and add the infrastructure into our system so that we can manage all chronic conditions, so that we're not just creating one isolated integrated clinical pathway, let's say for heart failure, but that a lot of what you build for the heart failure population is also applicable to other conditions. So had the privilege of working with Ed when we designed this model. And it has a long history and a lot of evidence of effectiveness. But basically, what it says is in order to have a good primary care system at the heart of your integrated accountable care system, you need to make sure that the health system is organized appropriately. You need to engage community resources and policies. You have to have a program of self-management support for patients that need behavior change and support. You need to look at the delivery system and think about how to do visits differently so that they are better designed for chronic care visits versus episodic care or whatever is coming in the front door. Improve decision support and clinical information systems that support the whole concept of population-based care. So being able to pull data from EMRs so that you can figure out which subpopulations you need to look at, what is their current care, creating exception reports, those sorts of things. And all of that funnels into this concept of a productive interaction between a patient that is prepared and activated to take care of themselves and a team that is also prepared and proactively reaching out to care for patient populations rather than waiting for them to come to the system. Ontario had taken the chronic care model back in, I think, about 2004 and created their version of it. It's the same basic concepts. They just wanted to blow up the community resources piece there in the left of the circle and talk about healthy public policy, supportive environments, and more community action. Now, before I go any further, what I'm going to do is just stop here for a second and see if there's any questions. Christine, I can't see any of the persons. Is there anything in the chat or any questions that people might have?
Nothing in the chat yet, Mike.
Okay. For folks, I've got onto the third step of population health management, and I'm now introducing this chronic disease management framework that all the teams have to work on. Are there any questions at this point? You can come off mute or raise your hand, and Christine will identify you. Not yet? Okay, I'll continue. So before we finish the last two steps of population health management, the implementation and reach and monitoring and evaluating, I want to look a little closer at this chronic disease framework that we have to, that the OHTs will be responsible for doing in the future, and you've already started in terms of integrated clinical pathways. So if we look inside this model, what do each of these things mean? So when I talked about delivery system redesign, what we're trying to do is improve transitions of care, especially people going from hospitals back to home or hospitals, to other long-term care, whatever it might be. So we want to make sure those transitions are effective and improve them where they need to be. Some of the questions you might ask is what part of the transition needs to be fixed? Is primary care being notified that one of their patients was in the ER and admitted and discharged a couple of days later? And is the information that the primary care provider needs from that discharge available to him or her? And then are they able to reach out and bring the patient in for follow-up care? We know that primary care follow-up visit after a hospital discharge within 7 days reduces readmissions by 50%. So those effective transitions are important. There needs to be stepped protocols for how we manage patients, not only in primary care, but in specialty care and in the hospital. And where we have those patients that are quite ill, we need to think about integrated case management and adding that case management functionality to the team to support the primary care providers and the team as a whole. Also inherent in this, and I'm talking about it without calling it out, so I should call it out, is that it's critical that we have primary care teams that function as teams, rather than primary care teams where there may be a number of people like a nurse, a MOA, a social worker, but they're all operating in silos. So a big part of what RISE will be doing in this next year is helping the OHTs and their associated primary care networks think about how to build teams in primary care and also how to support very small practices and solo practices by sharing resources across those teams. The other thing you want to think about in delivery system design is how do you get organized for a chronic care visit? Quite often what happens is the primary care provider opens the door and there is a patient that is very complex. They weren't prepared for the patient that day, and everything becomes a bit of a scramble to try and get ready to help the patient as much as they can during that visit. So part of the planning for these visits is setting these visits up ahead of time, having all the lab work there, making sure someone's done med reconciliation, and that the patient is part of that planning so that their agenda and the provider's agenda are both met. So those planned care visits are very important versus reactive visits. Recall functionality and regular follow-up is critical for these folks. And then, of course, we want to make sure that not only are the visits culturally sensitive, but that everyone can access those, and especially for our Indigenous population that may be spread out throughout the community and do have access issues. The other component in the chronic care model is self-management support. And what I've noticed working with the OHTs is that many of them are taking advantage of self-management support programs. It's, again, patients self-manage every day. The key is to get them to self-manage in a way that improves their health and increases their confidence that they can take care of themselves. The goal of self-management support is not to get the patient to do what the provider thinks they should do, but to give the patient confidence that they can manage their behavior, take their medications properly, follow their treatment plan, know the warning signs when they're getting sick. So those are really the goals of self-management support. And there are very simple self-management support strategies that providers can use to support patients. There's also a program across Ontario in each of the regions that provides self-management support training. Clinical decision supports. Here we're talking about evidence-based guidelines being built into care. Ontario is very lucky in that they have the health quality guidelines that people can be using, but we need to make sure that people are using them. We need to make sure that specialty care and primary care agreements are in place so that when patients are referred to specialty care, the right information goes to specialty care. And when they come back, the primary care's providers' questions have been answered. and they know how to move ahead. So that there's a real quid pro quo here, as well as specialty care educating primary care how to manage some of these special conditions that patients need. We talked about case management earlier. It's got to be built into care, so there needs to be agreements in place around what patients get case managed, how long they get case managed. That you don't want them to stay in case management indefinitely. They need to be stabilized and again returned back to home or to primary care. And then there's, of course, the social factors that we have to consider around patient care, the social determinants that impact the way they can take care of themselves and their quality of life. And patient and caregiver education. It's very important that patients understand why they're being asked to get certain types of care or certain types of preventive screenings. If they don't understand why, and those screenings happen to be invasive or difficult, or it's hard to get to the appointment, they're much less likely to show up for care. But if they understand why it's being ordered, they're much more likely to show up for care. So, clinical information technology, the EMRs, the hospital-based systems are the core of population health management and co-designing these care models. They allow you to segment the population, as we talked about earlier. They facilitate individual patient care planning across the different OHT partners. Hopefully there will be a day when the hospital is able to send the discharge electronically, that goes right into the EMR, and that the EMR then helps add to the patient's treatment plan, the existing one, or helps the primary care provider create one. Same with specialty care. If the specialty care changes the patient's plan of care, that is automatically updated in systems in primary care and other points of the system that the patient may touch. We want to provide reminders to providers and patients that they have needed care. Patient portals are critical, and there's been some work done in that area in the OHTs. System alerts for critical changes in patient status, and then the ability to monitor your performance. So some of the work that I'm doing with some of the OHTs is they're creating registries, a diabetes registry in particular, where they're able to see all of the patients with type 2 diabetes, the care that they have received, and the care that's missing. And it also gives you a population overview of, what's the average hemoglobin A1C for these patients, or average blood pressure, LDL, how many have a foot screen, how many have a kidney screen or on the right medications. Same thing can be done for heart failure, COPD. Again, registries are a disease neutral type of technology that supports delivery of care to patients and make sure that patients don't fall through the cracks. Talked a bit about community resources. I'm just checking the time here. And we want to make sure that we are engaged with the right social support agencies so that the addressing patients' determinants of health can be done with these social support agencies and doesn't fall solely on the healthcare system to do that work. I emphasize the social determinants piece, and I know I'm preaching to the choir when I say this, but this quote has always stuck with me since I met Dr. Gottlieb in San Francisco years ago. She said, "I diagnosed abdominal pain when the real problem was hunger. I confused social issues with medical problems in other patients also. I mislabeled the hopelessness of long-term unemployment as depression, and the poverty that causes patients to miss pills or appointments as non-compliance. In one older patient, I mistook the inability to read for dementia. My medical training had not prepared me for this ambush of social circumstance. Real-life obstacles had an enormous impact on my patients' lives, but because I had neither the skills nor resources for treating them, I ignored the social context of the disease altogether." Now, we've come a long way in the 15 years since Dr. Gottlieb made this point, but we still have a lot of work to do. And what happens in the patient's life outside of the healthcare system has much more is much more likely to determine their course of health than what we're currently doing in our system. So we really need to push very hard on how we address the social determinants and how we partner in this integrated accountable care system that we're trying to create, how we partner with social support agencies and other non-medical supports to make sure that patients, that these issues for them are addressed. An example of this is Mrs. C. She's a 78-year-old woman who's a mother of 3 children, married for over 50 years to her husband, Howard. They're on a fixed income. Inflation is making it increasingly difficult for them to make ends meet. In terms of how she eats, she loves casseroles for her family, which include a lot of processed meats and cheeses. And she's recently noticed a cough and shortness of breath when she and Howard go for walks. Now, I'm not going to go through this, but there's lots of different pain points. I'll leave these slide with you. But generally, what happens with the Mrs. C's of the world is she's before her diagnosis, she doesn't recognize her symptoms as indicative of COPD or heart failure in this case, and she seeks help through the ER. She comes in breathless one time and she seeks help. She's admitted. She's transferred out, and her primary care provider may or may not get the information that's needed and may or may not get her in within 7 days for a follow-up visit. Or she may have to wait 2 or 3 weeks to get a visit. In the meantime, she gets breathless again, and she had stopped taking the medication that the hospital gave her because she didn't understand it and it made her feel bad. And so she ends up in the ER again. And that cycle continues on and on. So it's the Mrs. C's of the world where we have to fix the broken parts of our health system here in transitions and helping patients understand their medications, along with the social determinants that Mrs. C is eating a high carb diet, high processed diet, and may not be getting enough exercise. So I'm not going to go through this, but I'll leave this with you. You can look at the different components of the CDPM framework and see where you might fix some of those parts of the system when you're doing co-design work and implementing the CDPM framework. The last 2 bullets I'll go through very quickly. Implementation. When you're ready to implement some of these changes that you're making, you just want to make sure that you've tested them, that they apply to all segments, apply appropriately to the appropriate segments of your population, that an equity approach is built into it. And when you design it, you test it on a small scale before going to implementation. You don't want to have failures on implementation. You want to have failures in your small tests so you can adapt it and move towards implementation. Relationships and building a community is more important for spreading change than any other factor. That's Helen Bevan of the National Health Service. And then finally, monitoring and evaluation. Once you've got the change in place, you want to make sure you continue to monitor it to make sure that the change is doing what it was supposed to do. You can look at the quadruple aim, now called the quintuple aim, when you add equity to that, and just make sure that you have a system of performance measurement to ensure that the system is working properly. So that was a wild ride. I'll stop sharing here and see if there's any questions.
There's a comment in the chat, Mike. It says, I am Mrs. C. I believe you have to have senior group practices.
Oh, terrific. Judith, do you mind saying a bit more about what you mean by senior group practices? Don't want to put you on the spot, but...
No, I've been frustrated for a while now with losing a doctor to retirement and then being assigned a group that I have different people that I get to meet. And as an 84-year-old person, sometimes I have challenges with answering the questions. Sometimes I get the wrong medication and have bad side effects. I mean, I'm really at loose ends. And when I sign up to get a new doctor, they say I already have a group and I can't get a new doctor. But in the end, I have been reading, I do a lot of reading, ask Christine, and I have seen that people are starting up senior practices that just a certain age group, all the same type of like COPD, I don't have that, but heart issues. We all have the subjects, you know. So in my mind, you should have like junior, medium, senior, and then break it down that way so that you are dealing with people who are familiar with what your symptoms are and what your possible reactions could be to the medications. And you have frustrations with pharmacists too.
Yeah, that's fantastic, Judith. I completely agree. I was thinking as you were talking, I started this work about 35 years ago, and the one thing I thought was, boy, I can't wait for the system to be better so that when I get there, it's ready. And we've done a lot of work and we've made lots of progress, but we still have quite a ways to go. And you've really outlined some of the issues that we've got to start working on. Um, Carol, you mentioned consider using chronic disease management workshops. Do you mind saying a bit more?
Yeah, sorry. There is already for those living with chronic diseases like diabetes, chronic pain, cardiovascular disease. Um, there are workshops, 6-week workshops already that actually utilize peer partnership for those living with those chronic illnesses. So they really do exist. They're out there. It's really about getting them accessed and certainly marketing them and getting them accessed for sure.
Yeah. Really great point, Carol. Yeah, the self-management programs in the regions do offer. It's called the Chronic Disease Self-Management Program. It's an evidence-based program that, as you say, it's peer-led, and it's a powerful way for people to meet and basically learn from each other about how to manage on a daily basis the chronic illnesses that they have. When we first started this work back in the 90s, these groups were very powerful and very popular, but the use of them has fallen off, which is unfortunate. Um, but yes, we do need to use more of those. And about 30% of the population will take you up on a group visit of some sort. So what I have seen in some OHTs is where they do group visits where they do the clinical work individually. So let's say you have 8 people coming in a group. They do the clinical work with the clinicians on the chronic disease, and then people end up in a self-management group. And so it's a great way to do both clinical care as well as self-management support. Stephanie.
First of all, I just wanted to do a shout out to Carol and say hi. Carol is their local hero in heart failure, I have to say. She's really leading the charge for developing these programs in our community, and we're going to leverage her expertise continuously as we go through this work. I did want to make a comment because my background has been in diabetes, well, it was in diabetes for 15 years. And one of the challenges that I often saw with, and I think this speaks a little bit to what you just mentioned, Mike, about the clinical piece, is the attrition or the lack of satisfaction with some of those self-management programs is the absence of condition-specific information. And I think that patients tend to so often feel overwhelmed by the amount of programs they have to get the information and the self-management strategies kind of wedded together. And I was just wondering if there's any between Mike and Carol, I don't know, and any other folks. I know there's lots of clinical folks here on the call. If there's any examples of where those two pieces are melded together nicely, clinical and self-management.
I'll offer an opinion, but I welcome anyone that has more knowledge of this. I think the diabetes education centers for diabetes, that is, are in a terrific place to do improved self-management support with patients while blending the clinical care. Many of them do good clinical care. The self-management piece there is goal setting and behavior change support for the patients, but for people that have been diagnosed with a chronic condition, there is so much for them to know. And often what we do is we sit them down for 2 or 3 hours and give them the 100 things that they have to do.
Fireworks.
Yeah. So I think there's the decks are great, but I think there's room for improvement there. Having things like decks for other chronic conditions would be very, very important in my mind. But I defer to the audience. Or is there anyone working in that sort of crossover between clinical care, education, and self-management support? Anyone
Um,
that wants comment, period?
yeah,
Carol?
I'm going to comment. Sorry. Yeah. Um, just just as an FYI, we did attempt to do a group peer education for the family health team under the heart failure care program. So we have a clinical aspect with heart failure team, which is the nurse and the pharmacist, along with our primary care providers in assisting with clinical management. But also we attempted a group education, and that was for the Heart Failure Awareness Month, which, well, it was for the Heart Month in February, but Heart Failure Awareness Month is actually coming up in May for us here in Canada. But sadly, not sadly, unfortunately, it was just a weather dependent day and we didn't get the turnout that we expected, but it was well received. And so we want to build on that and provide more peer support for our patients with, in this case, uh, heart failure. But I was just going to say that there are lots of online virtual peer support groups out there, and it's not just for the patients living with the chronic disease, it's also for caregivers um, that exist out there. And so we certainly will refer patients to, if they're amenable to, virtual groups like from the Heart Hub and the Ottawa Heart Institute. They all have online education as well as peer support groups out there. So again, it's really about tapping into what actually exists, what's out there already, and tapping into it.
Yeah, it's a great point, Carol. So yeah, directories are a terrific way of getting that information to providers. I think also for clinics that want to do their own sort of clinical and self-management groups, the organization of that can be quite time consuming. So we have to figure out a way to support them to do all of the administrative work that's required to get 10 people in the same room at the same time. It's a lot of work. So that's one thing to consider at the clinical level. Other questions? I see we've got about 2 minutes left. As I said before, lots of information in here. I'll provide the slides to Stephanie, and folks can use them whatever way they like. Please feel free. I think my email's in the slides. If not, I'll make sure you get it. Feel free to send me emails and ask more questions. This is tough work. It's tough work at the OHT level. It's tough work at the primary care network level. And it's especially tough for primary care to, if I can steal that advertisement, it's hard to fly the plane and build it at the same time, which is really what they have to do. So I think that the support that they get from folks like Stephanie and her team, and from the PCN is really critical to help them do this really important work. Any closing comments, Stephanie?
Yes, of course. I always have closing comments. Give me a microphone again. Stop. First of all, Mike, I wanted to thank you, as always, for your very cogent oversight of or overview of population health management. I think what I'd like to highlight is what my experience in population health management has taught me is you could start anywhere. If any of the pieces resonate, whether you're a nurse in a clinic or you're a physician with a practice, there's lots of places where we can start this work together. And as I said at the beginning, we are in a position where our OHT partners now have more resources to begin that work. So I think that's we're in a great spot right now to kind of dig in a little deeper than we have been able to in the past. And we've integrated we will be joining up our integrated care working group and our quality improvement working group under the leadership of Brianna here and Martin and some of our digital health support. So we've kind of teed up, I think, some very meaningful supports to evolve this work over the last couple of years. So I'm really happy with that. I just want to put a pin in, I think it looks like Carol left, but I just want to note the emphasis on peer as well, because I think that's a really important piece as we move forward is developing. It's particularly challenging, I think, in rural areas to develop strong peer support opportunities that aren't necessarily just virtual. So I think that's really something we want to cast our attention to and how we can increase that capacity as an OHT. But I think this is a great kickoff, Mike. Thank you. And I know you'll be back to where you and your team, or your team members will be back to support us in this work as we go forward. So
Yeah.
Thank you so much.
My pleasure.
Okay. Great.
Thank you, everybody.
Thank you. And this will be on our website. We will circulate the link for anybody to review.
Terrific.
Thank you.
Bye now.
Bye-bye.
Thanks.